Thank you, Jen. Good morning, everybody. I appreciate them putting me behind those two incredible speakers. So I'll do my best to keep you guys interested. My PowerPoint is not as exciting as theirs. You can tell they've done this for a while. But like Jen said, I've been in ophthalmology somehow for 20 years already. I've been involved in cataract surgery in some respect, whether as a technician or a surgical coordinator, for probably over 15 years. And I've seen a lot of changes even in my career. So we're going to talk today about biometry, what it is, some of the components of it, and what we can do as technicians to really help these patients get, a positive outcome with their cataract surgery. Like no financial disclosure, like Jen mentioned earlier. So to start off, what is biometry? Biometry is a mathematical calculation, but when it's related to ophthalmology, it's the process of measuring the anatomical characteristics of the eye and using that data to determine the ideal intraocular IOL power. There's been a lot of advances, like I mentioned, even in my career with biometry, but also with these IOLs. So that has really increased the patient's expectations for a good, positive post-op outcome. Cataract surgery has really become a refractive procedure. It's not just about getting them to see better now. It's really about reducing dependence on glasses, and patients are really expecting that these days. So we can really, as technicians, really play a key role in making sure that we're getting accurate measurements and helping with those good calculations for those outcomes. So before biometry, the first IOL was actually implanted in 1949 by Dr. Ridley. That patient had approximately a 20 diopter refractive surprise. So it took them still a couple decades after that to really figure out how to calculate these lens powers. And until biometry came about, they really had no way to do that. So patients were left aphakic. We'd take their lens out and they'd have to wear these lovely glasses afterwards that made their eyes look very large. And it affects their teeth apparently as well. So they had to wear these really high magnification lenses to correct their vision, because as Dr. Dickerson mentioned, the cornea has about 2/3 refractive power of the eye, but the lens has the other third. So that has to be replaced with something. These patients also tried to wear RGP lenses. And when you think about a 70 or 80-year-old patient trying to fuss with these lenses, it wasn't easy for them. So thankfully, biometry came about and IOLs became more readily available. The first form of biometry was ultrasound, and this is still used today in some cases. Ultrasound uses high frequency sound waves. They're admitted through this probe here, and the sound waves echoes off of the ocular structures and are diagrammed here as these spikes. So this is measuring the length of the eye. And you can see there's a spike for the probe, the anterior and posterior cornea, anterior posterior lens. This big gap here is going to be your vitreous cavity, retina, sclera. Occasionally you'll see some small spikes in the vitreous if they have floaters or anything. But this really kind of revolutionized cataract surgery. So the first form of ultrasound was contact. So this probe actually touched the cornea using anesthesia like we do for checking pressure. That really left, though, a high margin of error, because you could get some corneal compression from this probe touching the cornea. And depending on which technician is doing these measurements, some may have a lighter touch than the other. So this could leave a lot of, wiggle room for these results. That being said, ultrasound really helped, get these patients closer to refractive target, which is more than we can say before when they were left aphakic. But then immersion came about, and it's the same concept as the contact. It's still an ultrasound, but this probe is going inside this shell that basically goes around the cornea. It's called a Prager shell. That shell is filled with a fluid, and the probe is inserted into the fluid. So there's nothing touching the cornea, and you're not having that compression or that margin for error because of that. So immersion ultrasound is still used in certain cases today. It's not as common, but it's available as a secondary measurement if needed, which we'll talk a little bit about. And you'll also hear often this referred to as an A scan. The A stands for amplitude. So the newest forms of biometry is called optical, and this is what we mainly use today. And these are the IOL Master, Lens Star, which are the more common ones. And these use infrared light instead of sound waves. These machines are all automated. They're very accurate. They're non-invasive, so nothing's touching the cornea. And it's not only measuring the length of the eye, but we're measuring a lot of other different things. One being the keratometry, the corneal power, the white to white, and there's a lot of other different values that we measure that I'll show you a little bit later. And all of that data is now being used to calculate these lenses. And the more data you have, the better, the more accurate you're going to get. When I started in ophthalmology, we were still using contact ultrasound. So this is all progressed since I've been around. And the newest optical biometries are really able to get through dense cataracts. The original ones, one of their downfalls was that the light really couldn't get through a dense cataract or dense media. But now it does a really good job of that. So it's really reduced the need for the ultrasounds by over 90%, which is great because this is much easier to do for techs and for patients. So just to touch on a few of the major things that we're measuring with biometry, the first one, like we talked about, is axial length. That's the length of the eye from the front surface of the cornea to the retina. This number holds the majority stake in our lens power calculation. So it's the biggest percentage of what the calculation is based on. So if you look at this, you get if you have a 1 millimeter discrepancy in the measurement of your axial length, that's going to give you approximately a 3 diopter refractive surprise postoperatively. With these optical biometers, it's very difficult to get a 1 millimeter discrepancy or be off by a millimeter. But if you break that down further, being 0.3 millimeters off is still a diopter of over or under correction. So that's the difference of a 25.3 to a 25.6 is going to be a full diopter. And if you have these patients who, you're implanting multifocals or extended depth of focus lenses in, and they're paying $5,000 or $6,000 for their surgery, if they are a +1 post-op, they're not really going to be very happy because that's not only going to affect their distance, but it's also going to affect their reading vision as well. So some of the ways we can avoid axial length errors when we're doing these measurements, paying attention to the axial length of the eyes. Usually our eyes are 0.3 millimeters within each other axial length. So if you see that there's a difference between the two eyes, and often these machines will prompt you or warn you that there's a difference, it's good to verify that looking back at an old refraction or an old pair of glasses. Go as far back in the chart as possible. The older the better, because we know that cataracts can cause myopic shift. So you don't really want to go off your current glasses that you have. So going back as far as you can to see if you can find an old pair of glasses to verify that. So if you're seeing that the right eye has a longer axial length than the left eye, that patient should be more myopic in the right than in the left when you're correlating with glasses or refraction. And if you're unable to verify that, that's when going back and doing an immersion A scan can be really helpful because you can verify the axial length of each eye individually doing it that way. Also looking at the measurements of the same eye. I've actually had this happen to me as a technician doing IOL Master. I was getting 2 different axial length measurements consistently on the same eye. And that could mean that you're off your axis, or you're measuring on the optic nerve, or there may be a posterior staphyloma present that you're actually measuring on. So this is a B scan, a cross section of the eye. You can see this is the lens, the back surface of the lens. That shadow is going to be your optic nerve. And then below that, this bulging here, that is called the posterior staphyloma. So it's a bulging of the eye wall. The macula should be just above the optic nerve shadow, and that's where you want your fixation to be. So if you're measuring on that nerve, or if you're measuring on that staphyloma, you're getting a falsely long axial length measurement, which is going to give you the wrong IOL calculation, obviously. And then just keep in mind when you're looking at these calculations when they come out, a long eye or myopic eye has too much natural focus. You need a lower IOL power to correct them to emetropia, if that's what they're targeting. A short eye, a hyperopic eye doesn't have enough natural focus. So you need a higher IOL power for that. So if you have a patient who has, an average axial length is probably 23, 24 millimeters. If you have a patient who has a 29 millimeter axial length and it's telling you to put a 20 diopter lens in, that doesn't really make sense. So try to look back and see if there was an error somewhere to figure out, why that calculation was wrong. The next thing that these machines are looking at, or we have to consider, is the ocular media, and that's what the material of the components of the eye are made of. So these machines are using the velocity, which is the speed of light and sound as it travels through media. And each media has a velocity based on the density of that material. So the vitreous and aqueous of our eye have a velocity of around 1,500 meters per second. But if you have a patient that's had a vitrectomy and they have silicone oil in their eye, the oil is much thicker than vitreous. So that velocity is much lower. And these are all used in the calculations. So if we don't know what they have in their eye, it's going to assume that it's a standard, virgin eye, and it's going to cause miscalculation for your IOL. So that's where a thorough history is really crucial. Have they had a vitrectomy? What do they have in their vitreous cavity? Are they aphakic? Do they have no lens there? Are they pseudophakic and they're looking for a piggyback lens or a lens replacement? The different IOLs also are going to have different velocities. The PMMA lenses that were kind of originally used with cataract surgery are a much more rigid lens than the acrylic lenses that we use these days. So their velocity is going to be slower. So having a good history is very crucial. And this info needs to be entered into these machines before these measurements are done, because once they're taken, you can't go back and alter them. So if the data is incorrect, you're going to get an improper calc, or hopefully we catch it, and then you have to have the patient come back and have a repeat measurement done. The final major component that the biometry is looking at is the corneal power. Ultrasound biometry is not measuring this. It's only the optical, which is mainly what we use now, like I said. So it's looking at the keratometry, which is the curvature of the cornea. And Dr. Dickerson talked a lot about this previously. So these numbers are used to help calculate the corneal power and also the patient's astigmatism. So the corneal power is used in the convergence calculators, the formulas that we used to not only predict the postoperative outcome, but also the effective lens position. And that's basically where the lens is sitting inside the eye. All of the manufacturers of these lenses have a manufacturer suggested lens position, and it's a number that they give you that you plug into the formulas, and those can all be specialized by the surgeons as they go. But their corneal power is going to kind of take into consideration where that lens is sitting, what the refractive power of that lens is going to be. So having an accurate corneal power is important. It's the second most weighted measurement in the calculation formula. So like I said, axial length is the first, corneal power is the second, and this one has a 1-to-1 ratio. So like the axial length was a 1-to-3, corneal power is 1-to-1. So 1 diopter error in your readings are going to give you a 1 diopter refractive error post-operatively. I personally think it's a little easier to get errors in your K values with these machines, especially if a patient has dry eye, like Dr. Dickerson mentioned. Each blink is going to give you a different measurement. So when we're doing these, it's important to kind of make sure you're getting consistent K values, but also consistent astigmatism measurements as you go through these, just to make sure you're getting the correct numbers. So like Dr. Dickerson touched on, refractive surgery is something that's really important to know prior to calculating IOLs. Traditional machines, all of those topographers that Dr. Dickerson showed, they all measure on the presumption that the central cornea is a perfect sphere. And also it's presuming that the anterior and the posterior cornea have the same ratio. So the A picture is a normal cornea. B is going to be your RK patient. So as you can see, the central cornea is flattened, but also the anterior and posterior cornea are flattened. So RK, if people don't know what that is, RK was one of the original refractive procedures done in the 80s and early 90s. They were partial to full thickness radial incisions in the cornea in like a spoke pattern. And that was designed to flatten the central cornea to correct myopia. And it was great when it first came out, but for those of us that see these patients now, they're not the happiest patients. And like Dr. Dickerson mentioned, they're all at the cataract surgery age now. So we see a lot of these patients at Meridian, and they definitely present a challenge in calculating lens power. And we never, ever promise them that there's going to be any reduction of dependence on glasses because that cornea is so variable. C is our traditional myopic LASIK. So you can see the posterior cornea is unchanged. The anterior cornea is flattened. So you can see the change in the ratio from the periphery to the central cornea there. And D is our hyperopic LASIK. So the hyperopic LASIK, we actually have to try to steepen instead of flatten the cornea. So you can see the central cornea is mainly untouched, so that ratio doesn't really change, but peripherally the cornea is flatter, which gives it a steepening pattern. So there's a lot of really good formulas out there now to calculate post-refractive IOLs, but knowing what they had is important. The formulas on the AAO website are really great. They're very user-friendly. The only thing you really need to know is if they had a prior myopic, hyperopic, or RK procedure. RK is going to be obvious, but as far as what kind of LASIK procedure they had, most patients aren't going to walk in and say, I had myopic LASIK. They don't know. So just kind of talking to them about their history, what they wore glasses for, what they needed them for prior to their surgery, can give you an idea. Also, doing a topography can show you, if they have a flattened central cornea, they probably had myopic LASIK. If you have old records, that's great because you can enter all of that data in. And like I said, the more data you have, the better. But if you don't have that, the formulas now are actually really good at predicting post-op outcomes with no prior data. But again, with these patients, we don't promise them that they're gonna get glasses dependence from after cataract surgery. If we get within a half diopter or so, that's a pretty good outcome for LASIK patients. So some practices actually have a separate like addendum on their consent that they're post LASIK, and they understand they're not going to really, their expectation shouldn't be quite as high as a non-LASIK patient. So contact lenses, like Dr. Dickerson also mentioned, they do warp the surface of the cornea. So they need to be discontinued prior to these measurements. Patients don't like this. They hate this, especially if they're a high myope or a high hyperope, but it really is critical. And I find just a simple explanation to them, they understand that it's important. This is a permanent one and done procedure. So we obviously want to make sure we're doing it right the first time. So as far as the contacts go, typically 1 to 2 weeks for soft lenses is recommended, depending on surgeon preference. We do 1 week for non-toric, 2 week for toric lenses. RGPs at least 3 weeks, but I think this is underplaying it. I think going up to 6 weeks is even better. Those patients really hate this. RGP wearers love their RGPs. They see great in them, but they're the most important patients to be out of these lenses. So, and if even at that 6 week mark, you can always bring them back a second time to make sure that they've stabilized, because they can continue to shift. It can take weeks and weeks and weeks for their corneas to kind of relax back to their natural state. Scleral lenses, they can be measured same day. They vault the cornea, so they don't touch or change the shape of the cornea at all. So they can be taken out and be measured same day. This is especially helpful if you're considering using a toric lens, not only for the power of the astigmatism, but also the axis that we're placing those lenses. So as a technician, you always want to ask for their contact lens history. A lot of these patients will come into their cataract consultation wearing glasses because they know they're going to have drops that day. So we may not think about even bringing that up to them, but it's important to ask every consultation if they wear contact lenses, and mentioning it to them multiple times during the appointment is very helpful. You know, the more times they hear it, the better. And also documenting that we had this conversation with them, because we've all had the patient come in and say, oh, I was never told. Well, yes, you were. We wrote it down. We told you multiple times. So they have to be rescheduled, and that can push out their surgery, and that doesn't make anybody happy. So these are on the left. This is an example of the IOL master printout, and I apologize if it's kind of blurry and hard to see, but you can see how it's giving a ton of information. So up here in the left corner is the LS is going to be your lens status. So that is if they're phakic, pseudophakic, aphakic, their vitreous status. So if they have not had a vitrectomy, they have their normal vitreous there. And then the laser vision correction would be here. So prior LASIK would be documented there. Their target refraction is obviously very important for calculations because we want to know what we're shooting for. And then it shows us our axial length, our anterior chamber depth, which is the space between the cornea and the iris, the thickness of their lens, their central corneal thickness, their white to white, which is the width of their cornea, their pupil size, and all of these crazy numbers that get into some of those advanced optics. I wish Dr. Savage was still here because he could explain this a lot better than I can. But this is basically looking at the angle kappa, which is where their visual axis is in relation to the center of their pupil. If you're considering a multifocal lens on a patient or an extended depth of focus lens on a patient and their visual axis is way off to the side, they're not going to be looking through the center of that multifocal, and that's going to be an unhappy patient. So K values, and then it gives you a topography. It shows you if they were at the right fixation part. It shows you their K measurements, if they were good quality. So it gives you a ton of information. And like I mentioned, all of this needs to be pre-entered because it can't be altered after the measurements are done. So this on the left, and I'm sure a lot of you have seen this. This is a order at Flaum. We have a separate diagnostics department that does all these measurements for us. And this is what our order form essentially looks like for them. And this is where they're going to get all of that information to plug into those machines. So they want to know which eye we're working on, or which eye is going to be first. And then prior surgeries are all going to be listed here. And then there's a comment section if there's anything specific that you need to tell them. They need to know what the target refraction is, so they know what to calculate for. And then we can put more information in here about contact lenses, told the patient to be out, so on and so forth. So all of this, it's a lot to look at, but it's all really important information for the diagnostic team in order to make sure that they're getting the biometry done correctly. So this is my favorite term in ophthalmology, pearls. I was going through this talk with my wife last night, and she's like, what is pearls? It's like, well, I guess it's an ophthalmology term. I don't know, but pearls of wisdom, talking points that we're taking away. So just remember the axial length ratio is 1:3, 1 millimeter error for a 3 diopter refractive surprise. So if you do have a refractive surprise, you can go back and look at your measurements and see if there's anything that doesn't look right or is, standing out. Our K ratio is 1:1, 1 diopter to 1 diopter. And then, like we've talked about, documentation is really critical. The more we know, the better. So having this all done before the surgeon walks in is helpful, because it also can help them figure out what kind of lens they want to talk about with the patients. Because like Dr. Dickerson said, you don't want to put a multifocal in a refractive patient. We saw a RK patient with a multifocal lens in. He had a very small optical zone from his RK. He had iris transillumination. He was a very, very unhappy patient. So knowing their past history is going to be important in the lens discussion as well. And then if in doubt, double check, verify, remeasure if you have to. You know, the old saying, measure twice, cut once. That's kind of what we want to do here. So these patients have really high expectations. And, you know, we as techs and doctors should also have those high expectations with what we have available technology-wise these days. But you just have to know what you're looking for and what to watch out for.